Good morning and welcome to the 2026 Charter Meeting. For those of you I haven't met yet, my name's Professor Deborah McNamara and I'm President of RCSI. It's my great pleasure to welcome you back to RCSI today. Over the next 2 days, our programme will explore how innovation, leadership and evidence-based practice can improve patient outcomes, support the surgical workforce and respond to the challenges facing health systems in Ireland and internationally. Today we focus on prevention, precision, and the interface between surgery and emerging technologies. This morning we'll cover topics ranging from obesity, exercise, nutrition, to age-friendly health systems, to next-generation cancer care. The Johnson & Johnson lecture, starting at 1:45, will be delivered by Professor Antonino Spinelli from Humanitas University Milan, and he'll fast forward us into the world of surgical training in this high-tech era. Staying with the theme of technology, our afternoon symposium, Preparing the Surgical Workforce for AI, includes a diverse panel of speakers from academia, research, industry, and beyond. The afternoon session will wrap up at 4 o'clock with the 101st Abraham Collis Lecture, Harnessing AI to Improve Surgical Care, to be delivered by Professor Ewan Harrison of the University of Edinburgh. But the day doesn't end there. I know that many of you will be staying in RCSI right through till the evening for our annual video surgery meeting. And so our wonderful fellows, members and alumni office have arranged a networking buffet for you just upstairs in our Robotic and Technology Learning Village starting at 4:30. At 5 o'clock, Professor Barry Maguire will launch the RCSI Robotic Surgery Curriculum, and we will formally announce the €2.3 million institutional investment by RCSI in robotic surgical education, including the purchase of 3 new robotic platforms for surgical training and the opening of a new robotic education space at our National Surgical and Clinical Skills Centre. The video surgery meeting runs from 6 till 8:30, leaving you plenty of time to catch up with colleagues and friends later tonight. Tomorrow, however, some of the parallel sessions start as early as 7:30, so I do encourage you to download the programme using the QR code so that you don't miss anything. Our programme tomorrow is both topical and timely. Highlights will include the Carmichael Lecture by former Minister for Health Mary Harney and the President's Lecture on Quality and Safety in Surgery, to be delivered by international expert in healthcare improvement, Dr. Don Barrick. We'll also have an important session on clinical governance in surgery and a session co-hosted with our Early Career Surgeons Network. The Charter Day Robotic and Technology Learning Village would not be possible without the valued support of our industry sponsors, including Intuitive, Medtronic, Cornerstone, MedSurgical CMR, MMI, and Johnson & Johnson. I do encourage you to explore the exhibits. The coffee and lunch breaks throughout the meeting will continue to take place across the road in the exam hall, where we have a number of other sponsors, and I'd like to extend our sincere thanks to all industry sponsors for supporting the meeting, including AccuScience, Technopath, Applied Medical, BD, Johnson & Johnson MedTech, Lynch Medical, Intuitive, MDU, PEI, and the Medical Protection Society. Lastly, my very sincere thanks to our Charter Day Organising Committee, to the Conference and Events team, and to the entire RCSI community who've worked incredibly hard behind the scenes to make the next few days the success that I'm sure that they will be. A special word of thanks to our chairs, who have the very difficult task of keeping us on time on such an interesting programme. So without further ado, I'll hand over to our first chair of the day, Professor Paul Ridgway, who will introduce the opening keynote lecturer. Paul.
Thank you, President. It is my personal pleasure to introduce our first keynote of the Charter Day week. Professor Finucane is a consultant endocrinologist and an honorary professor of medicine in the University of Galway. He graduated from this university in 1998, and despite his busy specialist training in Dublin, he completed an MD in our sister university down the road on a topic which he's going to discuss today, specifically around diabetes and the relationship with excess weight. He then completed a 4-year postdoctoral fellowship in Cambridge And he settled into his practice in Galway, not content with just clinical practice, but also pursuing national roles in obesity and research. And he now runs an MSc, which is the only MSc in Ireland on obesity. Professor Finucane, it is a great personal pleasure to invite you to the stage and give us the keynote lecture on tackling the obesity crisis.
So thank you very much indeed for those kind words, Paul, and thank you to the President for inviting me to speak with you today at the opening of your meeting. I'm profoundly honoured and very privileged, and also very proud to be back at RCSI 28 years after graduating. It was a wonderful place then. And a very impressive learning environment, and it's obviously gone from strength to strength. So congratulations to everybody in the RCSI leadership who's been involved in developing this building and progressing the college's role in Ireland. So well done. So I'm going to talk to you today about how we tackle the obesity crisis. And obviously this is a vast topic, and I'm just going to touch on a few of the key issues as they arise, as I see them. Just to note my conflicts of interest, none of which have influenced the talk in any way. So we all know that there's an obesity crisis and that the prevalence of obesity has increased in Ireland in the last 4 decades or so, as it has globally. And really what's happened is that there has been a population shift in the distribution of body mass index. Okay, now if we're going to tackle that obesity crisis, if we're going to tackle this problem, we need to take the same approach that we would take to any public health crisis. And that approach was first described in what I would consider to be the most important medical scientific paper of all time. And that was published in 1985 by Jeffrey Rose, the so-called father of preventive medicine. If you haven't read this paper, you should. It's called Sick Individuals and Sick Populations. So important that it was actually republished in 2001. And when you go and you learn about the principles of epidemiology on the first day in most major universities, this is a paper that they will cover. And what the paper says is that you have to take a two-pronged approach to any public health crisis, and that includes obesity. So on the one hand, you need to try to shift the population distribution of risk factors to the left. Okay, so you need to change the environment that's giving rise to the public health problems such as obesity. So that's not so resource intensive. It has a small effect, but in a very large number of people in the population, and that reduces prevalence. Okay, so that's one approach that you need to take, but equally important, you also need to take the so-called high-risk individual approach for those individuals within the population who carry the highest burden of the risk factor. And as an obesity doctor in the west of Ireland, I'm very much focused with my surgical and other MDT colleagues on the delivery of this side of the two-pronged approach to the obesity crisis. So we care for people with severe and complicated obesity, and I'm going to touch mostly on that throughout my talk today. But it is important that we do not lose sight of the critical need to change the obesogenic environment that is driving this obesity crisis in the first place. Okay. So I mentioned that we run a service for patients with severe and complicated obesity. That is a problem that we're all aware of in the room has changed quite dramatically. The prevalence of severe and complicated obesity has actually gone up much higher in relative terms than the prevalence of obesity. Probably the best illustration of that in the Irish context is a paper that I was involved with a number of years ago now with Patricia Carney's group at UCC. And she asked the important question, what is the need for obesity surgery in Ireland? And specifically, she examined, led by Kate O'Neill, this project, the cohort called TILDA, the Irish Longitudinal Study of Aging. So that is a representative population-based sample of Irish adults over the age of 50 years. Okay, and what we found when we examined the prevalence of eligibility for obesity surgery was that 7.9%, almost 93,000 individuals in Ireland, fulfill the criteria for needing obesity surgery. Okay, so this is a very, very high number of individuals who are affected by what we would consider severe and complicated obesity. So let's flip that around and look at it slightly differently. You can see here that this is the distribution of BMI and TILDA, just a representative illustrative graph, and you've got a line here, and above that line, 8%-ish, 93,000 participants or so in that cohort study, 93,000 people in the Irish population fulfill the criteria for obesity surgery. Okay, now, anybody coming to our clinic on the medical side of obesity treatment in Galway, the very first thing I will say to any patient coming to our clinic is that by far the best treatment for severe and complicated obesity is obesity surgery. It is the most effective treatment in terms of the magnitude of weight loss, the sustainability of weight loss, and the durability of weight loss. And currently, it is the most cost-effective treatment for severe and complicated obesity, way more cost-effective than drug treatment, for example. I'll come back to that in a moment. Most patients we see in our clinic, even with severe and complicated obesity, decline obesity surgery as a first-line intervention. But it is important to acknowledge that it is something that we offer unless there are contraindications, which there are a few, of course, to people coming through the door as a routine. So I'm not here today in any way to suggest anything other than surgery is the way forward for people with severe and complicated obesity. But it's important to acknowledge that there's a high proportion of people, say in Tilda, who also have problems with obesity without necessarily fulfilling criteria for surgery. And in fact, when you look, about 36% of Irish adults over the age of 50 fulfill the criteria for medical treatment of their obesity by virtue of having a body mass index over 30. That's equivalent to 421,000 Irish adults over 50. Okay, now, that doesn't include people with a body mass index over 27 who've got, say, cardiovascular disease or diabetes. So this is a dramatic underestimate. So there are far more people who are going to benefit from drug therapy in the population than from obesity by current criteria for when we introduce these interventions. And it's important just to acknowledge that there's a difference there. I think that's very important. Okay, so what do we do in Galway aside from suggesting to somebody that surgery might be their best option or offering them drug therapy if it's appropriate and there are no contraindications? Well, of course, the fundamental kind of foundational intervention for patients with severe and complicated obesity involves helping them to modify their lifestyle. And that's crucially important, and we recognize that. And when we started in 2010, that sort of dark ages when it seemed that healthcare managers still didn't feel that obesity was a priority and there was an economic recession, so we had a sort of a skeleton crew in Galway of a dietitian, a physician, a surgeon, and a psychologist, and we had very little capacity. But we were blessed because we had neighbours down the road who were very, very good at providing structured lifestyle modification programs for people with specific diseases. And in particular, CRE, the West of Ireland Cardiac Foundation, is an international leader in this field. And they had developed a program called the My Action program, which was effectively a cardiac rehabilitation program for patients with prevalent cardiovascular disease. And that was developed by my colleague Susan Connolly, who has now come back to Galway from London, where this program was established. And my other colleague, Irene Gibson, who works at CRE, had successfully cloned that British cardiac rehabilitation program to a West of Ireland context. And so this had transformed the care, this sort of care for people in the West of Ireland with cardiovascular disease. And we said, look, is there any chance that you can clone that program again, but this time for people with severe and complicated obesity? And we got funding from Saleha Hospital Group, now West Northwest Hospital Group, and Healthy Ireland jointly. And we called this program the CRE Clan program, Changing Your Lifestyle with Activity and Nutrition. And this was a very successful program, a good example of activity-based funding or money following the patient. So we've been able to commission this care from an external expert organisation, and so we don't have to do this within our hospital environment in Galway because we just don't have the space or the staff. So this is a program that's been very successful, and we were able to, so Saleha and Healthy Ireland, just to acknowledge those. So we've been able to conduct an opportunistic prospective cohort study of patients with severe and complicated obesity going through this program, and we were able to demonstrate improvements, not huge improvements, but some improvements in weight and cardiovascular risk factors in the first 200 patients or so going through this program. And then we were able to conduct a follow-up study with a much larger cohort of patients where we examined quality of life and physical fitness, aerobic fitness, as well as mental health outcomes in these patients. We were able to demonstrate important improvements there too. So this is a fundamentally important foundational therapeutic strategy for our patients coming through our service. And it's a group-based intervention, and we think it's a good balance of efficiency and cost effectiveness, and also not spending a great deal of time, wasting time, frankly, sometimes waiting to see if a year-long cardiovascular or a year-long structured lifestyle modification program is going to be effective at fixing someone's obesity problem when clearly other interventions such as drug therapy or surgery are required. Now, we've also had an opportunity to try and examine what factors are associated with weight loss and health gains in this cohort, because there's significant heterogeneity in the response to the intervention. And this occurs across any intervention for obesity. And so we've been able to look at about 2,800 patients who've come through our service. About half of those are referred onto the CRE-CLAN program. They're all offered the program. About half will accept that invitation. So this is not a compulsory part of treatment. It's not something we use to evaluate someone's motivation or their willingness to engage in clinical services. Some patients have already been through structured lifestyle programs that have tried and failed. So this program, of the 1,122 patients who started the intervention, about 877 finished the intervention and we had outcome data. So that's a 78% retention, which is actually pretty high by structured lifestyle modification program standards. And you can see here that there's a broad variation in response. About 12% of patients after 8 weeks of intervention lost 5% or more of their body weight. Half of the patients had no significant change in their body weight after that short period of time. And in fact, 29% of patients gained weight on the intervention, you can see from this waterfall plot. So we were interested to try and figure out who does well with the program. So we identified that younger patients and those who are waiting a long time to get into the program, or people with depression, are less likely to finish the program once they start. And that older, basically cheerful old men are much more likely to do well in the program, especially if they attend the program, as you might expect. So cheerful old fellas, as we say, do respond better. What's interesting is that the magnitude of weight loss determines the benefits that patients see in this program. So we found for the first time, for example, that in a cohort of severe and complicated obesity patients, more weight loss, more purposeful weight loss was associated with improvements in mental health, both in terms of depression and anxiety scores and perceived quality of life. And also a substantial reduction in cardiovascular risk factors and improvements in metabolic health, such as lipid profile, liver blood tests, and diabetes control in patients with diabetes. So it's important to acknowledge the benefits of these programs, especially where patients do manage to respond well and lose weight. Okay, but this is the foundation sort of thing. This is not the be-all and the end-all of the therapeutic approach that we take to obesity in Galway. So what else can we offer patients? Well, really, there are two other things that we've mentioned, and I've mentioned these already. Drug treatment, and then I'll briefly touch on surgery. So the story of drug treatment over the last 15 or 16 years has really been remarkable. It was pretty pessimistic. So the day after I started work in Galway, the only remaining effective obesity drug, sibutramine, came off the market because it was shown to increase your risk of cardiovascular disease. Okay, so it was sort of one step forward, two steps back situation for obesity drug therapy, up until a bright spark called Daniel Drucker examined the saliva of the Gila monster, this creature here, and identified a molecule. God knows how he came up with this, but identified a molecule called exendin-4. And exendin-4 was basically a GLP-1 analog. It mimicked human endogenous GLP-1. GLP-1 is an important hormone in the control of insulin secretion when you eat, okay? And it accentuates, it augments the secretion of insulin from the pancreas after glucose is absorbed across the gut. So that's called the incretin effect. Now, the story of the development of these drugs is really fascinating, and I would recommend a book called The Magic Pill by Johann Hari if anybody's interested in this field. So Johann is a journalist who's taken semaglutide himself and has written about the discovery, the development of the drug, the pros and the cons. Very interesting overall read. But ultimately, these GLP-1 drugs mimic native GLP-1, which is a really short half-life. And GLP-1 affects lots of different tissues. It's produced in the gut by L cells, I always have to remember that, and it has lots and lots of different effects on different tissues. From a diabetes point of view, the GLP-1, the most important effect is on the pancreas because it helps insulin secretion in a glucose-dependent manner, so it doesn't cause hypoglycemia, which is great. But from an obesity point of view, arguably the most important effect of GLP-1s is on the brain, and specifically on parts of the brain that we don't have discretion over, so the subcortical, subconscious parts of the brain that influence appetite, satiety, but also hedonism around food and how you feel about eating. So it has very significant effects there, and that's how these drugs work to help people to eat less, which is what we need to do when we're treating obesity. Okay, and the drug trials are very compelling. Okay, so this is the step 1 trial for semaglutide. We've been fortunate in Galway to be involved in some of these trials. The first drug really was liraglutide, but in the interest of time, I'm going to focus on semaglutide because it's been such a game changer, and it's been in popular culture. We're all aware of Ozempic in the media. So with semaglutide, after a year of treatment at the obesity dose, the difference between placebo and active treatment was 12.7 kilograms, exactly 2 stone. So that's a very, very substantial overall average amount of weight loss with this drug. So looking at this another way, approximately 50% of patients in the trials lost 15% or more of their body weight. Okay, a third of patients in this trial lost 20% or more of their body weight, starting to approach the efficacy of obesity surgery, but only in a minority of patients. What's also interesting, and something that's a big challenge for us in clinical practice, is that there were about 1 in 6 patients who went on semaglutide in this trial who basically did not lose any weight. I mean, less than 5% body weight after 12 months of treatment is too little to really have a meaningful impact on health, okay? So that's a challenge in our field. So it's not just about weight loss with these drugs, it's also important to acknowledge the impact they've had on hard outcomes, okay? So the SUSTAIN 6 trial was crucially important because it demonstrated a reduction in cardiovascular outcomes in patients with diabetes who were taking semaglutide, okay? So it was twice as good as its sister drug, liraglutide. It led to a 26% reduction in cardiovascular outcomes, MACE, within 2 years of treatment, as opposed to 13% reduction after 4 years with liraglutide. Okay, and even more, and sorry, that's the graph there just confirming that, even more important, arguably, is the SELECT trial, which was the use of semaglutide in patients without diabetes. And that showed a 20% reduction in major adverse cardiovascular events after 4 years of treatment in people who didn't have diabetes but did have cardiovascular disease. So these drugs are, you know, very, very significantly changing how we approach obesity. And it's important to acknowledge that. And I think, in fairness, even though we're very clear about the effects of obesity surgery, the very large randomized control trials for harder outcomes like cardiovascular disease, sleep apnea, arthritis, fatty liver disease aren't necessarily there for the surgical side of things, where it tends to be more prospective cohort studies that have described the undoubted improvements with surgical treatment. And part of the problem is the effect size of surgery is so great, right? The weight loss is so great that you need far fewer numbers of patients in surgical randomized control trials to demonstrate, say, weight loss benefits or improvements in diabetes control. So in Philip Shower's STAMPEDE trial, which examined the benefits of obesity surgery on type 2 diabetes outcomes, there were 150 participants in the trial. In the SELECT trial for cardiovascular risk reduction with semaglutide in people without diabetes, there were 17,000 participants. You know, so it's a very different number of patients in these studies. It's important to acknowledge tirzepatide as well, a more recently available drug. I mean, there are even more exciting molecules coming down the line, but these are currently available in Ireland and are being used. And with tirzepatide, on the 15 milligram dose, the maximum dose, there's a 20.9% weight loss with this drug on average, okay? But what's interesting, and one of the challenges we face in relation to drug therapy, is that there's still a proportion of patients, even with a drug with an average weight loss of 21%, who will not lose any weight. So there'll be 9% of patients on tirzepatide who just won't have a response to it. And we are not very good at predicting who those patients are. All we can do is treat them, see how they get on after a few months, and then stop the drug if it's not working. We need to find better ways of predicting treatment response. So that's one of the challenges we face, is that heterogeneity in response to drugs. Okay. Another challenge we face with drug therapy, and it's really important that we acknowledge this, is the cost of the drugs. So they are prohibitively cost ineffective at the moment, at their current prices. And this has been examined in the literature. So essentially, the cost of the drugs mean that governments are not going to pay for them for patients. So if you look here, there's a very broad sort of variation in the costs that the drug companies are charging to different jurisdictions. And this is a study that said, well, what should they be charging to be in order to generate a profit, okay, for the company of 10%. And what it says here is that for the treatment of diabetes, semaglutide should cost approximately $10 per month. In America, at the time of writing here, it's come down in recent months, but the average cost was about $350 per month. In Ireland, we're similar to France, people are paying around about €135 per month. And our patients who don't have diabetes in Ireland have to pay for these drugs out of pocket themselves, okay? So there's no government funding for semaglutide for people who don't have diabetes. And what it should cost and what it actually costs are two very different things. The estimated price for obesity should be around about $40, okay? And at the moment, semaglutide at the obesity dose, the higher dose, costs Irish patients walking into a pharmacy about €330 per month. So this is a big problem. And I'm reminded of the wonderful story of the Volvo. Does anybody here drive a Volvo? Brilliant. So next time you're in your Volvo, have a look at the seatbelt buckle, and it says this on it. Do you know why it says that, what that's about? So just in the interest of time, in 1959, Volvo invented the three-point seatbelt, okay? And they immediately recognized the profound importance of this for passenger safety and driver safety, and they knew that if they tried to commercialize it, they could make billions by having much safer cars, but also that they would potentially save millions of lives if they released the patent for free. So in 1959, Volvo decided they would let all of the other car manufacturers adopt this technology with no cost, okay? And it led to a significant reduction in road deaths. So that was kind of sound of them, I think. And sometimes we've got to think beyond profit and look at the public health burden that we're trying to address. Another good example is this man from Ramelton, Bill Campbell, one of the most unassuming people I've ever met, one of the greatest people I've ever met, had the privilege to meet. Bill Campbell, along with Honorary, a Japanese scientist in the States working for Merck, identified the cure for onchocerciasis, or river blindness. Okay, ivermectin actually of COVID infamy. And he went to his bosses in Merck and said, look, poor people in Africa get this god-awful disease where they go blind from these worms in their eyes, where we can't commercialize this. And Merck said, okay, we'll do the same thing and we'll make this drug freely available or at cost available. And, had a huge impact on the prevalence of onchocerciasis in Africa with the drug. So sometimes the commercial approach isn't always the best. And when you think about the profits that the large multinational drug companies have made from these wonderful developments of obesity drugs, we need to get the balance right from a societal point of view. And I don't know that we're doing that at the moment. It certainly doesn't feel like that for the patients I see in Galway, 70% of whom did not finish secondary school. And many of these patients we see who would like to start these drugs can't afford them. It's a huge problem. Okay, and I mentioned that response heterogeneity to these drugs or to lifestyle modification is poorly understood. It's poorly understood for obesity surgery as well. And probably the best description of that is from Francois Patou's group in France, who conducted this SOPHIA study, an amalgamation of data from 9,000 patients in America, Europe, and Asia who had obesity surgery with 5-year follow-up. And they looked at basically 250 odd potential predictors of surgical response, and they were able to identify only 8 that were clinically meaningful, and that included age, weight, height, the type of surgery, whether or not you had diabetes, whether or not you smoked, and the duration of diabetes. So not much comes out when you try to adapt a machine learning approach to try and understand how best to treat obesity or predict response to obesity treatments. And this is described well in an overview by Padermo et al. In The Lancet recently, where you can see that this just shows you the distribution of the magnitude of weight loss with different interventions. Drugs on the bottom here, and the top left and the top right are lifestyle versus surgery. So this shows you that the surgery effect is dominant, okay? So the magnitude of weight loss is very big with surgery, but there's that variation that we can't fully figure out yet. That's a challenge that we face, I think, going forward. Okay, now I'm going to talk for 1 minute about the future, okay? So when I'm talking to endocrinologists or medical students about the future of obesity care, I think it is much brighter than it has been, thanks to the leadership of the National Clinical Programme for Obesity and the development of a model of care for patients with obesity in Ireland. That's been hugely important, and just to acknowledge Donal O'Shea's leadership on that, along with his colleagues at the obesity programme. Also crucially important to acknowledge the wonderful leadership of my surgical colleagues nationally, especially Helen Heenahan, but also in Galway, Chris Collins, Ollie McAnena, who really set things up in the first place back when nobody else was doing this in the West and took it above and beyond the call of duty, and Zolk Bodnar and Letterkenny as well. I should have a picture of Paul Cromwell here too, who's recently started in Galway, but I could not find a picture of him online. He must be in the witness protection program or something. But it's all about a team approach, okay? And our MDT in Galway has really developed over time. We could always do with more resources, and we are absolutely swamped. But it has been wonderful to work with dietetics, psychology, OT, physio, even medical social work, and nursing colleagues, as well as the surgeons and the endocrinologists to lead this. But the patient is at the center of everything that we do. That's very important. We're trying to develop those opportunistic prospective cohort studies where we can measure the same stuff at the same time in people as they go through our lifestyle programs or drug therapy or surgery. So that's going to be interesting. And just in terms of the research and the scientific development of the field of obesity in Ireland, we're always thinking about translation. I remember as a medical student here, we talked about from the bench to the bedside research. But I think when it comes to obesity, we also need to take an approach from the bedside to the bevy, if you like. We need to look at population level approaches. So it's not just medicine and bioscience, but philosophy, ethics, law, politics, economics, and marketing really come into this. And these are things that I'm going to shamelessly plug the MSc in obesity. These are all areas that we cover when we're studying obesity at a master's level in Galway. We've touched on the left-hand side, the population level stuff is really important, and the centrality of our ultra-processed food consumption problem has to be acknowledged by policymakers, I think. So we hacked into the Euromonitor, which is a sort of a food industry way of quantifying sales. And basically, I can tell you that the average man, woman, and child in Ireland every week consumes the equivalent of 5 packets of Skittles and 3 Mars bars and 10 digestive biscuits and 7 packets of crisps. And that doesn't include ice cream, soft drinks, alcohol, takeaway foods, baked goods, etc. So we have a massive problem with the population eating too much unhealthy food, and that's what we need to do. We need to address it. I'm working with colleagues in Trinity and in civil society organisations like the Irish Heart Foundation to identify these problems and describe them. And we've undertaken some formal, academic descriptions of the problematic nature of the relationship between the food industry and legislators that needs to be addressed as well. To end, as long as we are allowing McDonald's to sponsor the provision of accommodation to the parents of children in our flagship National Children's Hospital, we're going to have huge problems with obesity at a population level, which we are never going to medicate or operate our way out of. And so we have to address these determinants first. And just to acknowledge some of my colleagues around the country who've helped us develop our service in Galway over the last number of years, and thank you for your attention.
As per convention, Professor Finucane is going to be available later in the morning to take all your questions over coffee, but there'll be no questions now. And it always amazes me just how you can boil a life's work down into 25 minutes. And it was not only extremely informative, Francis, but very enjoyable to boot. And I look forward to being a slightly cheerier old codger in due course.